look for and interpret evidence and integrate it with practical information and regulations and so on. I've had a long career in publishing independent evidence-based advice on medicines for use by doctors and more recently vets. And I want to tell you a bit about what Veterinary Prescriber is and why I started it. It started about 12 years ago. I'd worked for about 20 years on an influential British human medicines publication called the Drug and Therapeutics Bulletin, which gave doctors independent advice on medicines. It was a pioneering publication that was started in the 1960s and was promoting the sort of evidence-based use of medicines long before anyone ever coined the term evidence-based medicine. It was based on an original publication that started in the United States and is still going, called the Medical Letter. And in the UK, the government used to pay for all prescribing doctors to receive this independent publication. And that's how a vet got to know about it, because there's a vet who's married to, at least one vet who's married to a doctor, and he wrote to the publication while I was working there all those years ago, saying vets could really do with independent information on medicines too, because they got a lot of information from industry, and why not start a similar publication for vets. So that's where I got the idea from. So I started Veterinary Prescriber. It's an online publication. The web address is veterinaryprescriber.org. We publish reviews of veterinary medicines. Importantly, Veterinary Prescriber is completely independent. We don't take any advertising or sponsorship or have any relationships with any vested interests, so the information is unbiased. It's funded by subscription because you can't produce information on nothing. We've got a team of people who are experts in critically reviewing evidence. We focus on the evidence. Evidence is king, which we summarize, but so often evidence is lacking, and that's where we need to integrate opinion and experience, and that's why we always consult specialists and general practice vets. Our reviews talk about the harmful side of medicines as well as the benefits, and we tease out the uncertainties. Because prescribing is about managing the balance between benefit and harm. So what we're aiming to do is to help people feel confident in prescribing through knowing all the pros and cons and uncertainties. And we also aim to help people think critically about medicines by explaining the critique. The information is published in the form of CPD modules, and we've reviewed most of the medicines used in the management of canine osteoarthritis. So on this slide here, I've sort of set out all the reviews we've done, split them into medicines that have a veterinary license, medicines that don't have a veterinary license, and unregulated treatments. And I think this slide will be useful for Gwen and our discussion. But first of all, what I want to do is ask you, Gwen, about how you get to the point of even deciding to use medical treatment. Because all medicines, we use medicines for their benefits, but all medicines have the potential to cause harm. So you don't want to use a medicine unless you have to. So how do you get to that point of deciding to use medicines?
I think, well, obviously I'm in a slightly unusual situation in that most of the animals sent to me have already been deemed painful or potentially painful by another vet or another professional. I see patients that are suspected source of pain based on the behavioural problem behaviour they might have. A behaviourist has expressed a concern about potential for pain, so they've sent the dog back to their vet, who's then sent them to me. That's a really common presentation. And then quite often I'm receiving referrals for patients which have long-term pain which is not adequately managed. In general practice, the general practitioner feels that they need some extra help to manage that pain. And then I also get internal referrals from my own colleagues with animals that have maybe had surgery or have gone for a surgical or neurological referral and are considered to be conservative management or post-surgical management need. And so most of my patients have already been judged to have pain. So obviously I'm going to evaluate the patient myself. I'm going to physically examine them, but and if pain is present, I'm going to make sure that they're on a licensed analgesic option as a first line. But in addition, I want to look at supportive care such as physiotherapy, exercise management, avoidance of hazards and triggers for injury and things like this, which is definitely something I've learned a lot about since I've known Hannah Capon with the canine arthritis management approach to the household hazards. And I think I want to make sure that I've ruled out or improved on those things before I start introducing more medicines, because, as you say, all medicines have the potential for some sort of toxicity, some sort of adverse effect. And then the other thing I'm going to do is discuss risks with the owner, make sure I book reviews, make sure we're monitoring response to therapy, so that if it's not helping, or if it's ineffective, or if it needs escalating, we can change that medication, and also reviewing within a certain time frame so that we can do a proper investigation if the problem is not resolving. I think, yeah, a lot of it comes down to monitoring. So, yeah, decision about when to start a medicine. I'm not really sure I've answered your question, Andrea. What do you think about that answer?
Well, I suppose yes, well, you have really, because as you said, the patients you see have already been through some degree of assessment anyway. But I mean, I suppose I was thinking about just making sure that non-medical interventions have been explored to begin with. I mean, I imagine there might be things like weight loss and
oh yes, I didn't mention weight loss.
yeah. But anyway, so assuming that a medical treatment is needed, I'm quite interested in the exploring the title of the talk that we were given, which is keeping yourself safe when you explore off-license approaches. I'm interested to know why are people interested in their own safety when they're prescribing?
Well, that's a really interesting question. I think vets really fear harming their patients. There's this sort of ethical phrase, "do no harm," isn't there, for doctors and vets? And when there's a big responsibility with prescribing medicines which have the potential for harm, and you can't necessarily predict that. I think you were referring to this information resource that you started your career, well, your earlier career you were involved with for doctors. But also, if I ever go to the doctor, they always check a database to check for interactions, because I'm on a few different medications and some of them are a bit scary to the GP doctor because they've been started by a specialist. They've got a database to check for drug interactions, and there's not really anything like that for vets. I mean, there are various information sources, and I use things like drugs.com a lot, which is obviously designed for humans, but we don't really have a good system like you might have if you were working in the NHS to cross-check before you prescribe a drug. Is it appropriate for this patient? Is it appropriate considering the other medicines the patient's on? So I think there's this real fear of harming your patient. And then there's also a little bit of a fear of disciplinary action or even litigation if you do the wrong thing.
Mm-hmm.
If you don't conform with the guidelines, prescribing guidelines, for example, and navigating the maze of licensed medications versus off-licensed medications is just another thing, another cognitive load for vets, really. So I think that's probably, talking about keeping yourself safe. So thinking about professionally.
Yeah, that makes sense. And, I'd agree with you. I think vets are very poorly served, really, with information sources. Like you say, there isn't even, an easily accessible interactions checker. I'll mention there is a very good one, actually, in Plums, which is an American online publication. They've recently developed, an interactive online interactions checker, which we use routinely anyway when we're producing the information. It is very useful.
Yeah.
But they're most most people don't have access to that kind of information. And then
That's a subscription based
it is.
resource, isn't it?
Yeah, I mean, it'd be great if that kind of resource is integrated into the practice management systems, prescribing systems. It would be brilliant, but that's not available well in the UK, which leads me to say as well that we both work in the UK, so our discussion is in the context of UK regulations, and obviously there'll be similarities in other parts of the world, but there'll be things about regulations that differ in different parts of the world. So I wonder if is this a good place to kind of talk about the cascade?
Yeah.
Which is there to help vets choose to manage the benefit harm equation. So, and I'd be interested if you could talk us through how you negotiate the cascade when you're prescribing.
Yeah, so this is a government-based guidelines and for vets as to how they may prescribe drugs. And it's all relating to the licensing of drugs or use of drugs that don't have a license. And licensing involves granting of a marketing authorization. So they're kind of the same thing, really. And this requires that strict safety and quality standards are met. And that license is awarded by the Veterinary Medicines Directorate or in the or the European Medicines Agency, and I guess in the US is at the FDA.
Mm-hmm.
And in the human field, the same thing occurs with the MHRA. And this license, this marketing authorization, will determine the condition the medicine is used for and the recommended dose, and things like duration, how it's given, etc. So step one on this prescribing cascade for vets is using a veterinary medicine that has a marketing authorization or a license valid in the UK for the indicated species and condition. Step two is the same, but it refers to those drugs that are licensed in Northern Ireland. So we now in the UK have to, in Great Britain, we have to use a special import certificate if we want to use a drug that's licensed only in Northern Ireland. And step three is a veterinary medicine with a marketing authorization valid for use for different species or condition. And into this step, you will be able to include sort of off-label use of a medicine that's licensed to be used in a different way as well. So I think we're going to talk about some examples in a minute, but an example of a drug that's used a lot that is licensed for use in dogs is Pardale V, but certainly I am using it quite a lot in a different way. So it's only licensed for 5 days at quite a high dose, but a lot of people are using it for chronic pain for long-term use at a lower dose. So that's an example of an off-label use of a licensed medicine. And then sometimes we're using medicines in cats that are licensed in dogs. Because in certain situations, obviously there are some licensed in dogs which are definitely not safe for cats. And then step four is where we actually branch out to use human medicines that have a human marketing authorization valid in the UK or Northern Ireland, or the authorized veterinary medicines from outside of the UK and Northern Ireland. So, for example, those licensed in Europe or America, and we need a special import certificate for those. And then step five is if you compound a drug into a different form as a pharmacist or a vet. So those are the main steps. I don't know how you want to take this next.
Yeah, I think would I be right in saying that some people see the cascade as being kind of restrictive, or like a sort of limiting people's freedom rather than what it's meant to do, which is to offer more flexibility.
I guess the point of it is to try and help vets decide and make decision based on those drugs, primarily the drugs that we have most information about and most evidence for, because they've done the appropriate research, appropriate clinical trials have been done to gain a marketing authorization. So they've had to jump through certain hoops and meet certain standards. But there are a few things that mean that this prescribing cascade do restrict the way we practice. So, and a really classic example, sorry, I'm going back to Pardale again, is cost. So Pardale V is paracetamol with a tiny bit of codeine in it. And by effectively, vets should be prescribing that rather than human paracetamol, which is cheap as chips. Human paracetamol is licensed for over-the-counter use for humans. And it's not, if you went into a pharmacy or a supermarket and said, I'm buying this paracetamol for my dog, they should say, I'm not allowing you to do that, because it's not licensed over the counter for dogs. So if you've got a client that is financially restricted, and there are other examples, are we actually inhibiting our ability to effectively treat those patients by being required to use the veterinary license version when a human version exists? That's a question I'm asked all the time. And it very explicitly says in the guidelines that the human version being cheaper is not a reason to prescribe it. You've got to find another reason as a vet to justify prescribing that human version of the drug. So that's an example of how it maybe restricts us a bit. And another examples are where a medicine has gained a license, meaning, I think one of the modules that veterinary prescriber has done is looking at a new product called DogStem, and that is a equine umbilical cell mesenchymal stem cells product, which has now got a veterinary license in the UK and Europe. I'm not sure if it's licensed in America or not. And the fact that this has a license now, maybe, you've gone back to that slide, that's quite useful, maybe means that we have to use that over some other therapies that we might actually think is more indicated for the patient. But we need to justify that. As vets, we're allowed to say, actually, I think in this situation, the patient would be better treated with amantadine than a stem cell therapy. I've found that all these other drugs haven't really helped for this dog, but I want to treat it with amantadine. I haven't tried dog stem, but I don't think dog stem is appropriate in this case. So you need to be able to justify it.
Yes. Well, I think, the cascade is not a set of instructions for prescribing, because when a product is licensed, the regulators decided in general that the benefit outweighs the harm for the licensed use, and that's why they've outlined all the contraindications and adverse effects to help vets use it in a way that's least likely to cause adverse effects. And that's the principle behind the cascade, is using the product which has the greatest likelihood of benefit, least likelihood of harm. And but the vet is the only person who knows the patient. So then it's the place of the vet to decide for that patient what is the best treatment. And I think Pardale V is a funny one, I think, and I'm going to be challenging, I think, because Pardale V is, I would argue that if you want to treat a dog with paracetamol, there isn't a paracetamol licensed product for dogs. There's a paracetamol codeine licensed product. And I'd say that codeine is thought not to have. Sorry, I've got to plug my battery thing. My power source has fallen out. There we go. Codeine is thought not to be having any effect in dogs because it's not thought to be very bioavailable. So to me, I would say that Pardale V is an illogical product. It's a very old product. It's been on the market for donkey's years. There haven't been any new studies ever, I don't think, since it's been on the market. So thinking logically, I would say that if you've not got a good reason to use codeine in a dog, why would you be choosing a paracetamol codeine combination product? You see, I think and go as far to say that I think the fact that it's there as a licensed product and people think they need to use it because it is the licensed product is keeping it on the market. Why can't a company produce a paracetamol? It can't be that difficult to produce a
Yeah.
paracetamol only product that's licensed for a dog.
Technically, you could start going really going off piste here, but technically, the next product you should use if you want to prescribe paracetamol is the one licensed for pigs.
That's true. Yes, that's right.
It's unrealistic in the
Yeah,
formulation it's provided. But
yeah,
there is a veterinary license
indeed.
formulation of
Yeah,
paracetamol
yeah.
alone, and that
And that
is
would be part of your consideration. Is it practical to use in a
yeah,
dog? And if
exactly.
it is, then that's the one you should use.
Yeah,
And if it's not, then you go to the next stage. But I can see, these are the sort of trickinesses
yeah,
tricky things that vets are challenged with. And you're right. You mentioned dog stem. I mean, before dog stem was licensed about a year or so ago, there have been unlicensed forms of stem cell therapy available. And because stem cell therapy is considered a medical therapy, now that there's a licensed form, then yeah, that would become the first choice if you're considering stem cell therapy, I would
yes,
say. But would you say that comes before, because it's in the license list, would
yeah.
you say that comes before gabapentin?
No,
I
I think you have to consider it because it's in the license list. You have to consider it as a first line.
Do you do that? I mean, why aren't you thinking about it in terms of, that the dog needs an analgesic and it's
Yeah,
got neuropathic pain, so it needs a
yeah.
treatment for neuropathic pain? Would
Well,
you
so
be
yes, the
thinking?
most of the time I'm just going to completely bin the idea of giving the stem cells to the
Mm,
dog if I'm trying to treat neuropathic pain, for example.
mm,
But ultimately, if I'm going to reach for an unlicensed medication, I need to make sure that I have checked there aren't any license. But you're correct. That would be a totally inappropriate therapy for a dog with neuropathic pain. So maybe my example earlier about comparing it to amantadine is not appropriate. But I think amantadine similarly has a sort of delayed onset of action for anti-hyperalgesic effect, and maybe we should be considering injection of a stem cell instead. But I don't think that's not what I think. That's just a
yeah. I mean, what this points to as well is the sort of, the lack of comparative information that's available on treatments that would, if it was
mm,
available, would help vets to know when and,
yeah.
what order to use treatments. And, that's one of the sort of big uncertainties I see that, people have to contend with.
Yeah, I think most of the studies that have certainly in a lot of the drugs named here have been studied against placebo rather than studied against something that you might call standard care.
Mm-hmm.
Um, and so the results are slightly misinforming because you could say a certain drug has a 50% chance, 50% of dogs responded to this drug. But actually, a certain percentage of dogs would have responded to being given carprofen or meloxicam in the
Mm-hmm.
the same group of dogs. So there are no head-to-head. Most of
Mm,
these drugs don't have some of them do, but most of these drugs don't have head-to-head studies
mm.
with a existing drug that we know lots about.
That's
Um,
right, yes. And even if there are, they tend to be non-inferiority trials, which are
hmm,
only designed to show that the test treatment is no worse
yeah.
within a certain margin than the comparator. So, not useful for choosing between treatments. Um, so
But
yeah.
it gives you that information to know that you've got a selection of treatments you could use in a particular
Mhm,
dog. So if you're presented with a dog that has not tolerated two different non-steroidals, for example, I'm mostly then not going to try a third. I'm going to try and treat this dog without non-steroidal anti-inflammatories, at least for a time, even if I try it again in the future.
mm,
And so then if I've gotten some non-inferiority studies, I can at least say, well, actually, this might be an appropriate alternative.
mhm. Yeah, fair enough. And I mean, another point is, if we were looking at this table a few years ago, that the this category will be very sparse. I mean, there are more
Mm.
licensed choices now. It seems.
Yeah, we have had quite an increase in the number of licensed medications we've got, but I would sort of come back to this thought about the quality of the studies and things. I think there's probably, we're going to talk about this a little bit, but some of these medicines, a bit like you were talking about Pardel V.
Mm,
We have had a recent study for acute pain with Pardel V actually, but its license wasn't based on particularly good efficacy studies. And then we had Traleave was licensed before possibly the only study that shows, in my opinion, any effect for chronic pain, based on the fact that it had been used a great deal, tramadol being used a great deal in many dogs with no adverse effects. And really, I think this is how it ended up managing to get its European license. And as a result, the British government also licensed it, because at the time we were still in Europe, and we've got a different situation now. We don't necessarily have to license European licensed medications, but
mm,
I felt quite upset that got a license, because, well, my opinions about tramadol use and tramadol efficacy and the evidence base.
mm, yeah.
And
And
so,
that's why it's important to look at the evidence and.
mm,
And also, I think another important point is that the medicine. There isn't somebody who sort of sits down and says these are the medicines we need
yeah,
to treat dogs and cats. These are here. I mean, it's commercial
yes,
considerations that bring products to market. So we don't necessarily get the ones we need.
yes. I mean, we're going to come back to Pardel again. I I would absolutely love us to have better studies, or there's some long-term studies for paracetamol in dogs, because
Mm,
there's a huge variety of opinion, rightly so, because it's based on the experience of the individual practitioners, about how effective paracetamol can be for chronic pain. And who's going to pay for the research? So,
mm, yeah,
is there going to be a commercial company that pays for the research? And you could argue that having a commercial company paying for the research actually is a problem anyway. So
mm,
it should be funded independently. But
mm,
then, that's got to find that money to
mm,
do those studies.
yeah. I had heard that the Royal Veterinary College have been doing some studies on paracetamol recently, but
Yeah.
I don't know much about that. But hopefully they'll
Yeah.
do something.
Looking forward to seeing results of those.
Yeah, okay. Should we now focus on the benefits of treatment? Because it's important that vets and clients have a realistic expectation of the effects of treatment. But it seems to me that it's not necessarily an easy thing to communicate.
Mm,
Um, and I want to, here we've got an example to talk about, which is oops, not that one. We're going to use the example of Librela, Bedinvetmab here,
mm,
because I think this is quite interesting because the clinical trial. So Librela was licensed on the basis of two clinical trials in dogs with osteoarthritis. And clinical trials usually are assessing the effects of the treatment on a very specific outcome. I mean, all clinical trials usually have a primary outcome measure, which is the most important result because that's the outcome around which the size of the trial is based, and so on. That is the sort of most powerful result usually. So and so this is what, and the license is awarded on the basis of what's been shown in the clinical trials. So for Librela, the primary outcome measure and the measure of the treatment success was a reduction of at least 1 point on pain severity score and at least 2 points on pain interference score, as assessed by owners using the canine brief pain
mm.
inventory at 4 weeks. So, I mean, that's quite a very sort of specific thing. And I'm wondering how you translate that into a sort of tangible, how's my dog going to benefit from this treatment?
Yeah, well, it's very specific, but also very subjective, isn't it? And this is a validated scale that's used a lot in research and well-respected scale, but it's obviously reliant on the owner making that assessment, and um, the yeah. So as you say, their statement about success is based on that outcome. The study itself also had some secondary outcomes, and I think certainly the USA trial didn't have any objective measures. So, but maybe the Europe trial as well. I can't remember. Sorry,
I
you might
don't
be more
think there
familiar.
were. No, I can't
So,
remember.
assessment of lameness, for example, using force platform. There's lots of discussion about how useful those measures are, but the idea is you take some of the placebo effect out. That's another debate as well. So whether you can get placebo effect in an objective measure like force plate analysis. But the idea is you want to use several assessment methods to make a decision about treatment success. But ultimately, you need your primary outcome measure, and that's what it's assessed on. So in this example, um, that's just the I think is just the owner assessment and the owner pain scale that was used. How to describe? What your question was? How to
Yeah,
explain it
well,
to
really, yes, because I mean, I was thinking, that is quite a specific thing, and it's
yeah,
hard, hard for me to think, what would, if you were explaining to, what does that mean to an individual?
yeah,
This is your dog is going to, you're going to notice 1 point less, what does that mean to somebody? I'm not sure. I mean, I wanted to contrast that with, the wording of the license indication, which is, clearly it shows that it is alleviating pain to some extent. And, so that's what it's licensed for, the alleviation of pain.
mm,
But I'm thinking, what is it, what should a client expect when you start treatment with it? You know, and another aspect is how the company communicates the benefit. I mean, the slogan for Librela is "Give dogs more days of play," which is
mm,
that is a kind of another step away. I think that is perhaps a tangible benefit that you might see, but
yeah,
maybe not. And it's just because not. And another thing is that not all dogs benefit.
yes.
um, it's about I suppose explaining the range of outcomes that there might be. I mean, I wonder, do vets commonly use the number needed to treat in communications?
Just to
Yeah,
let you
so
know, 10 minutes, guys. All right.
Oh
10
gosh,
minutes.
thank you.
We need to hurry up. Yeah, so the number needed to treat is, so it would be tempting to look at the Librela study and say half of dogs didn't respond. Um, but actually, that's not including a consideration of the placebo effect. So you could say to the client, I don't think it was, it was under 50% response rate, but the placebo effect was nearly 20% in the European study and over 30% in the American study. And those are fairly classic. Well, placebo effects usually around the 30% mark, isn't it? Um,
Mm-hmm.
I think having to get into discussion about placebo effect with the client
Yeah.
is really
No,
tricky.
we won't do that. No.
Number needed to treat.
What we'll do is go on to talk about sort of
Yeah.
balancing against, the benefit against the
Yes.
risk of harm.
Yeah.
And I mean, the point I wanted to bring out here was how there's established treatments that have been around for a long time that we know quite well, and when new treatments come along, um, as I said earlier, in the licensing process, they've sort of found out the most likely adverse effects and defined what the contraindications and so on are. But there's an important time dimension with adverse effects, and it is important to be aware that with new treatments, what we know about adverse effects is kind of limited because it's based on clinical trials, and as we've seen, clinical trials of in veterinary products, companion animal veterinary products usually include several hundred patients. So this is just a chart showing the how many clinical trial I was going to say participants, not participants, subjects you need to reveal adverse effects. And
Yeah.
if you've just got a few hundred, you're really only going to probably pick up the most common side effects. And it's not until things are used in a much wider range and number of patients that you're going to pick up the less common adverse effects, which is why adverse effects kind of, the more we that's why we learn more about new products as time goes on, and why pharmacovigilance and reporting adverse effects is so important.
Yeah, absolutely. You've taken the words out of my mouth. I think with a new drug, everyone gets excited about a new drug, but it's really important to report any side adverse effects we see as vets, because what we've seen, and using Librela again as an example, is an awful lot of popular discussion about side effects, and no sort of much less veterinary assessment of real side effects that have been seen, and probably not enough reporting of those side effects, so that the regulators and the marketing authorization holder can actually gather that information and actually then log them as accepted side effects that have occurred, and then allocate that kind of common, uncommon, rare category to them, which is what helps vets guide owners through the decision making about whether to treat or not. Those sort of risk ratios and things. So most of our veterinary studies, as you say, are underpowered to detect anything other than the common side effects. And yeah, we need to be vigilant in the first few years. Well, we always need to be vigilant for potential side effects, and we got to try and explain that to the client and take that into our benefit cost or benefit risk discussion about whether it's going to help the animal or not. It's all about monitoring, isn't it? Monitoring the animal, monitoring the response.
That's it. Yeah. Okay, we've only got 10 minutes left, so actually we're going to have a lot of time to talk about. We were going to talk about, gabapentin and pregabalin. I mean, it's really you're getting on to. I'll just run over what we hope to talk about. Gabapentin, pregabalin. Maybe how you choose between the two, based on what evidence is available, and what's happened there?
There's something odd's happening with your slides. Yeah, that slide.
Oh, there are only a couple more. Okay, there was a slide on amantadine, and whoops, looks like it's not all there. It's a bit odd.
It's probably best to stick to one, because we're going to run out of time.
Okay, then. All right. So this was really, sort of wrapping up with talking about uncertainties, because there'll always be, missing information, just information that doesn't exist, that you need to take into consideration, and about how you deal with that. And we were going to talk about gabapentin and pregabalin. So yeah, so this slide is just kind of looking at the sort of common features of the two.
Yeah.
Then there maybe we're all right. And then some of the differences between them, and how you'd decide, make a decision about using them, and how.
So evidence base for these two drugs is weak, to say the best. I think we're getting a growing evidence base for how gabapentin affects dogs and cats. We've got some studies coming through now. We have less evidence for pregabalin. I think I listened to a talk yesterday, and we were talking about pregabalin is prohibitively expensive if you buy the licensed form Lyrica. Gabapentin is much cheaper. So that's often a treatment decision based on cost. But there's actually some quite significant differences between how the two are metabolized and, not metabolized, how they're absorbed, and things like dosing intervals. So I also would point out that I come across an awful lot of vets who think gabapentin is licensed because it's become so commonplace to prescribe. And I think sometimes there's a bit of a lack of guidance or information out there for which are appropriate patients to be given gabapentinoids. So, really they're appropriate for use in animals which have a central nervous system sensitization component or a nociplastic component to their arthritis pain. So for arthritis itself, in its primary form, you wouldn't reach for a gabapentinoid, but actually we know that constant barrage of nociception coming from an arthritic joint or multiple arthritic joints does actually lead to central sensitization, which is where these drugs may be more appropriate. And then also, as you say, anxiolysis and things like that. So choosing between the two really at the moment requires vets to delve into the published evidence and as to big up our veterinary prescriber again. I guess there is a module on this and decision making between the two. But my personal choice is usually to reach for pregabalin first because it's usually effective twice daily, whereas I find gabapentin almost always you need to dose it 3 times daily to have a decent effect. And I find the effect more predictable with pregabalin, the way it's absorbed. And the major side effect of pregabalin, which seems to be less of a side effect in my experience, I'm interested to hear other people's experience, but that it's an appetite stimulant. It really makes dogs and cats become quite a lot more food oriented. Most of my patients need to lose weight, not gain it. So, are we creating another problem? Dogs that become frustrated around food. So the complex decision making, I think, is probably the summary. What else do you want me to expand on, Andrea? There.
Let's see. Well, I don't know. Another one was amantadine. We have got. Oh, yes, they are there. They just took time to load up. We just a quick look at amantadine. Similar. There's not a lot of evidence. There is some evidence there of its use in conjunction with meloxicam.
Yeah. So there was that study in 2008 done by Duncan Lascelles' team, which is which was great at the time, was sort of transforming to actually have a clinical study for an unlicensed medication and a completely new type of medication that vets might want to use. And we've then, since that study, we've gained lots of experience with the drug and we've become quite confident prescribing it. And I certainly myself am reasonably confident it's going to have a beneficial effect in most of my patients. But again, I'm always wanting to monitor their response because not every patient benefits from it. And then, I'm actually prescribing probably more frequently now memantine, which has no published evidence. But the reason for that is twofold. One, we're likely in many countries, we've lost the right to prescribe amantadine because it's now a protected antiviral for humans. And that's probably going to happen in the UK fairly soon. Memantine, I consider, is an equivalent drug, which is more potent and quite a lot cheaper, actually. And we've got no restriction on making that decision because neither of them are licensed. But we need some clinical studies for memantine to guide prescribing of that drug.
Because there is the caveat that because something similar doesn't, there probably be there might be some effects that are different adverse effects, or you can't extrapolate completely from one drug to another similar one. But no, that's but as you say, the situation's changing. And then finally, before Hannah appears again, these are some of the common uncertainties. We've already talked about, knowing how treatments compare with each other, when to use them in a disease process, and some of the treatments have only been studied in sort of mild to moderate disease, and there isn't very much evidence in severe disease, for example. How you use them safely with other treatments, and also long-term efficacy and safety. Efficacy trials are, these. If you're using the treatments in chronic pain, you're potentially using them over quite long periods of time, but trials are usually last no longer than 6 months at
Yeah.
best, and so
Yeah.
often don't have long-term efficacy data,
Yeah.
or long-term safety data. Sometimes we don't know the effect of using, like something like Pentasan. The trials are only about a single use, a single treatment. We
Of
don't know
course.
the
Yeah.
same with dog stem. There can be, a lot of missing information, things that we don't know.
Certainly.
So finally, the way to deal with all those, you've mentioned monitoring.
Yeah.
That seems a really sort of key point.
I think having that discussion at every stage with the client, the likelihood of the benefit versus the risk, those trade-offs we keep talking about, monitoring. Always check back with your patient. You need to see if your treatment's working. You need to see if it's having any side effects. You need to stop it if it's not working. It's potentially toxic. So it's the same things we've been talking about all the way through, really, isn't it?
So if you're keeping your patients safe, you're keeping yourself safe.
That's nicely rounded up.
That's a really nice roundup. That's excellently done. No, really, really interesting. And I think for the vets and nurses that have been listening, you've given people a lot more data from which to work. But I think for the allied professionals and canine professionals that are listening, hopefully you've stimulated a lot of sympathy and empathy about what we have to juggle on a daily basis. There isn't just a case of grabbing something off the shelf. There's a lot of thoughts behind it and a lot of nerves, because I know when you've got an owner that doesn't necessarily believe that their dog is in pain and you're saying, no, I really do want you to believe me and I really want us to trial this.
Yeah.
And, the fact that they could have an adverse event because we don't know. It's a very kind of tricky area, isn't it? Now we've got some questions. Yeah. It is scary. Got some questions. I'm going to fly through it. Paracetamol. I'm worried I might come unstuck here, particularly as my colleagues prescribed the lower doses. This is a common problem. 10 mg per kg formulary dose. Can I double check where we stand with owners buying paracetamol themselves? Can I check on the advising dose, etc.? So take it away, Gwen.
I think we need to review that formulary entry. It's on my to-do list. I think we've got more recent evidence for the effective doses in acute pain. So some studies that have been conducted recently, but then those studies, one was in intravenous paracetamol at 15 milligrams per kilo compared to a non-steroidal anti-inflammatory, and the other one was in Pardale at full licensed dose, so always for short-term use. But I think it's fairly well established that we should be using bigger doses than the 10 mg per kg 3 times a day. So, I mean, if you want my opinion, my personal practice is to use routinely 15 milligrams per kilo 3 times a day. I know colleagues use much higher doses than that and are confident that their patients, they haven't had any adverse effects in their patients. Up to sort of 25 milligram per kilo 3 times a day. I think my emphasis is on the 3 times a day dosing. So finding a dose that you're happy with to use 3 times a day because it's short acting. Monitoring liver parameters and kidney parameters in your patients if at all possible. Obviously, financial constraints are often a problem. And just emphasizing the fact that practice needs to be guided by a vet. You shouldn't really just be telling your clients to go out and buy paracetamol from the supermarket, because technically you're telling them to break the law. I know it's done widely, but what my practice is to write it down. What I've advised, it's got to be written down somewhere, and ideally write a prescription, even if the client then goes and buys it from the supermarket. If you've written a prescription, then you've covered your back from a prescribing point of view. You've given the client very specific guidelines that the pharmacist would put on a label for them. I think that's the thing. If you tell your client to just go out and buy paracetamol, give the dog half a tablet 3 times a day, that's not been written down. And when you're prescribing, it should be written on the package, and the client should have access to things like safety information as well to read, not just to verbally have that information.
Do the BSAVA still do the drug the drug handouts?
Yeah, they do. I think that also probably says 10 mg per kg 3 times a day, because it was written when we were being super cautious. And I think a lot of people are using it chronically now, and there are very few there are very few. I don't know of any reports. We should be yellow card reporting even off-label, well, definitely off-label prescribing, but we aren't. Vets aren't reporting it. This is what scares me, that if there's been adverse reactions to paracetamol, it's not always being reported, and therefore other vets don't know about it.
Yeah, me and Gwen were talking about this because I'm doing the masters, so looking at it from a human perspective, and paracetamol is falling off its high pitch of being safe and effective. With the bigger and bigger and bigger studies and bringing more and more data together, the low side effect profile, and therefore it's great because it's got low side effect profile, starts coming up because the benefits are getting less. So the seesaw starts going the other way. And that's really fascinating that, paracetamol has been established, for 20, 30 years, and data is only coming out now where they're reflecting back and going, well, look, actually, we're still learning.
And the problem with these really big sort of meta-analyses is it kind of evens out the data so much that you end up with a decision that is not useful. But actually, in an individual patient, paracetamol might be extremely useful for chronic pain. In another patient, it's not useful at all. So you still have to be prepared to trial a medication and monitor the response.
Yes, and that's what comes back to everything that we do, be it lifestyle, exercise, interventions, pharmaceuticals, nutritional. When you're managing chronic pain, there's a huge element of, I need to have clinical reasoning skills to implement this. But I then need to monitor it. My owner needs to be educated and on board and able to be part of that care team that can go, is it working for that one? So with the paracetamol, there's still debate about cascade wise. Can you come off the cascade for financial reasons? No. So Pardale is higher than paracetamol, so that is not allowed. That was in the question. And can you come off it?
Maybe you want to say that. I don't know. You see, you're talking about two different things. I think you're talking about paracetamol and codeine versus paracetamol. I don't see that there's a cost argument there. Because
the pharmacist speaking.
Because it's not, are you deciding to prescribe paracetamol and codeine, or are you prescribing paracetamol?
Yeah, good point. So I think that's usually my justification for using paracetamol, is that I don't want the dog. I don't think the dog needs codeine. I don't want to put a drug into the dog that it doesn't need.
I think the companies need to produce a licensed paracetamol for dogs.
So you've just answered the next question, which is great, because I was just about to say, what about the fact that it has codeine? So thank you for reading our minds. There's coming on some Librella questions. Tramadol. What is your thoughts on tramadol having a veterinary license when we know that its efficacy in management of chronic pain in dogs is poor? Given the low availability of the active metabolite in this species, under the cascade, we should be using this in preference to gabapentin and amantadine. Apparently, the license was granted in the UK by piggybacking on an Italian product. What is your thoughts?
I think that's what I said earlier. Maybe I didn't verbalize it quite as eloquently as that, but that it didn't get its British license due to an efficacy study. And it's only recently there's been any study that actually may show a positive effect in dogs, I think with hip arthritis. If it's used for 4 weeks, it may decrease central sensitization to then decrease the number of OA crises that dog has in the month following treatment. But there's none of the published studies actually indicate any benefit in acute or chronic pain. And I know that Claire Rusbridge will actually say she doesn't see any reason to use tramadol unless you're going to use it for at least 2 weeks and assess its benefit to that individual patient. And many dogs are, of course, going to be taken straight off it because of the dysphoria that some dogs get from the metabolites. So there's a science and an evidence base for actually, I know it's licensed, but actually I don't see that it's useful from an evidence base or a personal experience base.
It's true that licenses don't always keep up with the evidence. There are other examples, and I think that's why the cascade, that it's not an instruction. It's vets need to know. Need to know the evidence. Need to know medicines, and you have to justify your prescription.
Yeah.
You have to prescribe it.
So clinical notes is absolutely key. Just making a little jot down.
Because I think the regulator is there to tell vets what to prescribe. Obviously, you mustn't break the law, but the cascade has the principle is is not harm, doing as least harm as possible.
Yeah.
And it's the vet who knows the patient, and you can know the evidence on the products that you've got, at your access to. And you have to be able to justify it, and that's why clients have to consent to the use of off-license treatment. And if you can't justify it to them, then you shouldn't be using it, probably.
I know. So I'm going to do 2 short questions, one for Gwen. What dose of gabapentin do you advise for analgesia? At BSAVA, there was a range of advice from naught to 20.
Naught.
I love that. I love they chucked in naught. But that's true, because there's some people out there that really are opposed to the use of gabapentin. So that's where the naught comes from. And then, like yesterday, Robin Downing was very, very convinced that it's part of many of her chronic pain plans, but she's using very low doses over a long period of time. So what's your
I think my usual advice is to start at 5 milligrams per kilo 3 times a day, and escalate. Some dogs, if they've shown any sort of and cats, if they've shown any past sensitivity to sedative drugs and things like that, then I might be a bit more cautious and start them on lower doses than that, and then titrate it up. But yeah, I was interested to hear those comments yesterday. I think maybe I should try some lower doses. But the reason I start at a lower dose than most surgeons or neurologists would start at is that you'll see the side effects of ataxia and sedation much more if you start at 10 milligrams per kilo, which is probably where you're aiming for in the initial treatment of a dog with osteoarthritis. But I start at that smaller dose and work up to 10 milligrams per kilo, and then, as necessary, work up to nearer 20 if the dog needs it. But I think there are some you may see some effects at lower doses than those I'm recommending. But it's always, how well are you assessing that animal's pain? How big is the placebo effect?
Yeah, no, absolutely. And I learned from you. I think I go even more cautious than you go, because you made me cautious. And I tend to start with gabapentin just in the evening, and then I increase the frequency just in case they did get really wobbly. They're going to be asleep.
I always warn clients that if the dog has a lot of that sort of ataxia and weakness at the start, some of my patients have got really weak hips and lumbosacral disease.
Last thing they want to do
really
is fall.
mustn't slip.
Yeah.
So I just talk to them about safety and making sure the animal's got plenty of non-slip flooring. And the best place to slip is when you're just getting out of bed. So there needs to be a mat outside the bed and things like that. So that's really important when you're starting this drug. But then once they get past those side effects, it can be very valuable. But I see a lot of dosing once and twice a day, which I think possibly helps with sleep and anxiolysis, but it's not really going to give you an anti-hyperalgesic effect, I think. That's my opinion. Drugs are very short-acting.
No. I've got a question for the lovely Andrea. Roughly, how long are like human drug trials? So somebody asked, comparative to animals, what are we talking with these human ones in general?
Sorry, the duration or the sort of
duration? Yeah.
No, it'd be similar. They, several months. The trials that are done to get licenses be a similar order. The same as the problem. Often there's lack of long-term data on efficacy and safety.
Yeah. A very quick one for Gwen. Have you used tramadol successfully in cats?
Yes.
And how do you deliver it? Because it's very bad tasting.
Oh, that's more difficult to answer. I like the three treats method, where you have 3. You've got some sort of cat safe moldable paste. Make 3 little balls. One of them has a tramadol tablet in it that you've carefully molded around the tablet, so there's no trace of the tablet on the outside of this paste ball. The cat gets you train the cat initially with no medication, 3 treats, and then once you get the cat used to that, you give the first paste ball has no treatment, the second one has the tramadol in it, the third one has no treatment.
Nice.
So the cat always gets that last treat. That only works if your cat likes food.
Yeah. No, that's correct.
Really, really tricky because it's very bitter.
Yeah, definitely. All these questions, guys, just because we're going to try and grab a break here, we will deal with this. Now, Librella's obviously a hot topic. It's a hot topic.
Throughout
It's a
the Congress.
it's a recent arrival to our little toolkit. What we were chatting about before going live is potentially bringing together a little bit of a board of opinions into canine arthritis management. We've got a number of people that advise for us, a number of people that are actually CAM advisors that we can bring together at a later date, and we can talk about this, because there's a lot of questions about it. And I think, we need to give it more time than trying to rush through a question in 1.3 minutes. With regards to the final thing, I would say, I really like this comment, and I just want to leave us to think about it. Should we be writing our reasons on clinical files why we're picking drugs off the cascade? However, we seem to be edging more towards defensive medicine, and sometimes at the detriment of the patient. I think that's a really good point to leave with. And the reason I'm doing that is because I know that there's going to be non-veterinary professionals listening to this. And one of the aims of the conference is to unite us and to sympathize and empathize and work together better and have an understanding of what other people do on a daily basis. And it's working both ways. It's not a one-way street, it's a two-way street. I want people to be able to work together better by empathizing of what they do on a daily basis. So I think you're right. There is that feeling in vet care of getting more and more defensive in your practice. So we just need to look after each other. And Paul should be popping back to round off. And I'd like to say thank you so much to Gwen and Andrea. Both of them are CAM advisors. I'm extremely lucky to have these women in my life. I'm just going to give them a little bit of a thank you. Andrea's on our ethical board. We have a board of ethical advisors, as is Gwen. She's also another advisor too. And CAM tries to remain fiercely independent, like Andrea is with Vet Prescriber. And I have these women, there's 5 powerful women hidden away that make me behave. So if I'm to ever fall off the path of independence and do something that might jeopardize CAM's intention, I have them to tell me otherwise. And I just want to say thank you so much for the time that you give me. Righty ho, Paul, over to you.
Very much, guys. Really enjoyed that. Great to see lots of comments and questions coming in. Speakers, you can go backstage now should you wish. And just a quick note to everyone, because we're having some issues with the virtual event bag. I know many of you have received your links. We're struggling to get hold of the company that provides the bag because we know that some of the links aren't going out correctly. And some of you may have received an email today that says it invites you to submit something into the goodie bag. That's incorrect, obviously, but the link in that email you received today will actually take you through to the event bag as a viewer, as an attendee. So if you have received an email today that says Chronic Pain Symposium, your invitation, your virtual bag is ready, click that, go in, have a look around. There's 60 placements in there from partners, speakers, associations, everyone we could find that wants to give you additional resources, freebies, goodies, etc. Anyone who hasn't received a link over the last few days, do check your spam folders. We're going to send a feedback survey out post-event, probably on Monday. If you could just let us know in that feedback survey that you haven't received it, we will either find a contact to the company who can help us, or alternatively, we'll work on a workaround that makes sure that you get access to everything, even if it's on a page that we build on our website. So you will have access at some point to everything in the goodie bag. We're working on it. It's a bit of a tricky job, but rest assured we'll try and make sure that you get access to everything. Right then, what I'm going to do now, because we're going into a break before the next session, we've got a quick video to share from Cam that talks about suffering in silence with dogs. So I'm just going to play this now, and then we'll have sort of a 10-minute break. Thanks, everyone.
How can I be of help?
Can you describe how you're feeling to me? Okay, can you show me? Can you point to where the problem is? I'm afraid I can't help if you don't tell me. Stop. You're in pain.
Well said as well. There are plenty of resources on the CAN website. I'm sure many of you will be aware, but those of you who haven't visited the website yet, there is a ton of information and helpful resources on there. So we'll share some links post-event. Right, we're going to go and get the next speakers set up. We'll take a quick 5 minutes to grab a drink and stretch the legs, and we will see you soon. Thank you.